Hi, my name is Dr. Johnny Sexton, and I have been a pediatric audiologist for 40 years and the executive director and founder of the CARE Project. The North Carolina Early Hearing Detection and Intervention Program has partnered with the CARE Project to produce sensitivity training for professionals who work with families who have children born deaf and hard of hearing. This training video is designed to enhance the sensitivity of audiologists on the emotional journey of families and to bring about a shift in the culture of communication as audiologists deliver information to parents regarding the diagnosis and treatment of children with hearing loss. Many audiologists do a great job, and this training is not to insinuate otherwise, but merely to raise the level of awareness on the part of audiologists about the emotional state of parents as receivers of unexpected news. I hope you enjoy watching this training video and gain greater insight as well. According to the National Institutes of Health website, hearing loss is the most commonly occurring congenital condition in newborns. Approximately 2 to 3 out of every 1,000 children in the United States are born with a hearing loss in one or both ears. More than 90% of deaf babies are born to hearing parents and have no known risk factors. Hearing loss is invisible or not obvious. As stated in the 2013 Joint Committee on Infant Hearing supplement to the 2007 position statement, during the early stages of life, the brain builds the nerve pathways necessary for understanding auditory information. For these reasons, we want to identify hearing loss as early as possible, by the time a child reaches 3 months of age. This enables parents to pursue treatment options early so that a child can learn to communicate comparably with his or her hearing peers. The most intensive period of speech and language development is during the first 3 years of life, a period when a child's brain is developing and maturing. If a child is not exposed to language during this period due to hearing loss, he or she will have more difficulty developing spoken or signed language and reading skills. Hearing screening is the first and a very important step in the early hearing detection and intervention process. Infants who do not pass newborn hearing screening need to have follow-up testing to determine if hearing loss is present. Intervention should be started as quickly as possible to provide optimal language and learning outcomes for the child. For the benefits of universal newborn hearing screening to be fully realized, screening must be appropriately coordinated and linked with diagnostic and early intervention services and the child's medical home in a way that is family-centered and culturally competent.
We wake up and we hear. Growing up with children and, learning to speak properly, you never realize that the hearing is so important. It can be so involved.
EHDI sounds like READY and stands for Early Hearing Detection and Intervention. EHDI has 3 parts. The first part is the Newborn Hearing Screening Program, the initial test of infants for hearing loss. EHDI also includes audiological diagnostic evaluations to confirm hearing loss and early intervention programs, including medical services, early intervention services, and family support. In the year 2000, 44% of all newborns were screened for hearing loss. Today, almost all newborns are screened. Because of this, each year thousands of infants with hearing loss and their families are benefiting from early identification. Every state has an early hearing detection and intervention program, also known as EHDI. The overall goal of the program is to have every newborn screened and rescreened by 1 month of age. This includes the hospital screen and the follow-up outpatient rescreen. By 3 months of age, the infants that do not pass the newborn hearing screening should have an audiologic evaluation that results in a diagnosis for each individual ear so that they are receiving early intervention services by 6 months of age. Early intervention also includes amplification if it is appropriate. In the 2019 Joint Committee on Infant Hearing position statement, these goals are even more ambitious, encouraging a 1-2-3 timeline rather than a 1-3-6 timeline. North Carolina data reported to the Centers for Disease Control and Prevention, the CDC, indicates that 230 babies, or 27.5%, who did not pass their newborn hearing screen in 2017 were considered lost to follow-up. The national average is 25%. If you think about it, this statistic is high. If hearing loss is identified at a later age, the child's communication skills may lag behind those of their normal hearing peers. Why is this number so high?
I'm Marcia Fort, the North Carolina Early Hearing Detection and Intervention Program Manager, also known as EHDI. In 2016, we had over 30% of infants who were considered lost to follow-up following a failed newborn hearing screening. Lost to follow-up means we know that that infant failed their hearing screening, but we have no record and no report of them having follow-up. Audiologists are key to reducing that lost to follow-up number. EHDI coordinators are fairly confident that maybe as many as half of those children actually were seen by an audiologist, but the results were not reported to the EHDI program. Every state and territory has a reporting mechanism. Please take the few minutes after your evaluation of young children to report those results to your state EHDI program.
Screeners are often the first ones to share unexpected news with a family. How this news is delivered to a family can and will influence whether or not a family follows through to the next step in the EHDI process, the outpatient rescreen or the diagnostic evaluation. The role of the screener is vitally important in reducing the number of babies who are lost to follow-up. In keeping with the EHDI 136 goals, pediatric audiologists are responsible for obtaining accurate, detailed, and timely diagnosis of hearing loss in an infant by 3 months of age in accordance with their state's pediatric diagnostic protocol. This evaluation may need to include the assistance of an ENT physician if sedation is necessary. Minimizing the number of visits required to reach diagnosis is important in reducing the number of babies who are lost to follow-up. If permanent hearing loss is diagnosed, appropriate referrals must be made. Counseling about and connecting families to early intervention services, family support services, and an ENT physician are critical. Other referrals may include genetics, ophthalmology, radiology, or cardiology.
We find out a bit about this support group through our audiologist, and they provided immediate information about the group. They gave us web pages and information about other parents in the same situation, and we started to use this. We joined the group very soon after that.
It is important to call parents before the diagnostic evaluation with instructions on how to prepare their baby. Be specific with your instructions. Do not feed your baby. Do not let your baby fall asleep. If possible, leave other children at home. Bring someone with you. Inform parents that the time leading up to the appointment will most likely be stressful. A hungry and tired baby is a fussy baby, but the payoff may be well worth their while. Their baby must sleep to get a complete evaluation. Tell them an evaluation can take up to 3 hours. As hard as we try, however, an additional appointment may be necessary. On the day of testing, use simple and straightforward language. Ask families if they have questions. Ask if they would prefer to discuss results as the evaluation progresses or once testing is complete. Remember to keep information simple and easy to understand. Use interpreters when necessary. Remember to pause and allow families a chance to process information and come up with questions. Giving families something tangible to take home and read is valuable. Parents will only remember a portion of what you say. Consider creating a resource packet including their baby's diagnosis, definition of terms and acronyms used in diagnosis, description of referral agencies, and any other pertinent information.
At the end, after we knew the diagnosis, if we could have had more information to take home. I don't really recall taking home any literature that we could read, that type thing, and it was a lot to digest. It was a lot thrown at us at one time, and if we had something maybe to go back and review to take in, that could have been helpful.
Know your own limitations. It is okay to refer to another facility if your office is not equipped to perform diagnostic ABRs or if you feel out of your comfort zone. Keep 136 goals in mind. Do not wait to refer to another facility. There is a very small window of opportunity for the ABR to be completed in a non-sedated state.
My name is Holly Shown. I am the parent of a child with hearing loss who is 16. I can remember when he was an infant and we would go to the audiologist, and I have actually audiograms from when he went, and I can look at those audiograms now and look back and they say, even on the graph part, there would be question marks about where his hearing was, and then at the bottom of the paper it would say, return in 3 months. And so we would, and then time passed and there was no diagnosis, and so we ended up, when he was almost 2, going to another audiologist, and we had to go through all of those things again, all of the appointments, the cost, the time. He had to be sedated, and finally we got our diagnosis. And so we lost a lot during that time, things that we will never recover, because that first audiologist, I just wish she would have known her own limits and thought to pass us on to another facility that would have been better trained and better able to work with an infant.
I'm Dr. Philip Griffin, an audiologist and currently the president of the North Carolina Audiology Association. Management of infants and children with hearing loss is one of the most important things that audiologists do. As an audiologist, if you're not comfortable seeing an infant or a young child with hearing loss, please feel comfortable, and I encourage you to refer them to a pediatric audiologist so that child can get the very best care.
Don't forget to report your results to your state's EHDI program. Your EHDI program is here to help you and your families reach the 136 goals. Call us or we'll call you. It's also important to remember that achieving cultural competency and having a high level of awareness of social determinants of health can have a profound impact on our effectiveness as clinicians in communicating sensitive information to families. Why is cultural competency important to our work? A person's values, beliefs, and behaviors about health and well-being are shaped by many different factors, such as race, ethnicity, nationality, language, gender, socioeconomic status, physical and mental ability, sexual orientation, and occupation. According to the U.S. Department of Health and Human Services, cultural competence is the ability to provide services to clients that honor different cultural beliefs, interpersonal styles, attitudes, and behaviors, and the use of multicultural staff in the policy development, administration, and provision of those services. The goal of culturally competent healthcare services is to provide the highest quality of care to every patient, regardless of these factors.
For me, as a person who has both vision loss and hearing loss, cultural sensitivity is key, and so an audiologist being aware of that is crucial. And also asking the patient what will work for them. Like my audiologist knows that when I make an appointment and I'm going to be coming into his office, he needs to wear a black shirt so that I can understand him clearly. And also that maybe he needs to sign with me using the tactile method. So, he knows what works for me and is willing to work with me to make our communication successful. He knows to let me know before he turns the lights off, things like that.
Achieving cultural competency is an ongoing learning process and is often developed in stages by building upon previous knowledge and experience. Healthcare providers must be taught how to provide services in a culturally competent manner. According to the National Center for Cultural Competency at Georgetown University, it is almost impossible to know everything about every culture. Therefore, training approaches that focus only on facts are limited and are best combined with approaches that provide skills that are more universal. For example, skills such as communication and medical history-taking techniques can be applied to a wide diversity of clientele. Curiosity, empathy, respect, and humility are some basic attitudes that have the potential to help the clinical relationship and to yield useful information about the patient's individual beliefs and preferences. An approach that focuses on inquiry, reflection, and analysis throughout the care process is most useful for acknowledging that culture is just one of many factors that influence an individual's health, beliefs, and practices.
As for my children, I have 4 children. 3 of them are deaf. One has a cochlear implant. One doesn't have any cochlear implant at all because he has autism also. And then my youngest is too deaf. He has ANSD, and I'm sorry, I can't tell you what ANSD stands for, but I'm pretty sure if you're an audiologist, you know what that means. My youngest is 3, the one with ANSD. He's 3, so we're going to wait and see what he wants to do. But my oldest son with the cochlear implant, he was born in New York. And there's a very strong deaf community in New York. And so there was already a strong relationship between the deaf community and the audiologists locally. So everything went fine in New York. And then when we moved down here, I felt like there was no partnership between the deaf community and the audiologists. And I've noticed that here in North Carolina, the audiologists just focus on fixing the problem. And I get that, but it would be nice if we had a good partnership between the audiologists and the deaf community. Now, for my oldest child, when I moved here, he needed a hearing aid, but they automatically started talking about cochlear implants. And that reminded me of my experience when that was pushed on me, and so I immediately said no. And that particular audiologist was in Greensboro, and she said, okay, well, I can't provide you my services. And I said, okay. But that reminded me of my audiologist that I had in Chapel Hill, and so I drove to Chapel Hill, and we couldn't see the same audiologist. But I did get an audiologist for my son who tried to sign and who respected us. And we sat down, and she explained everything to me and got an interpreter for our meetings. Now, my son was able to wear hearing aids, but he had allergic reactions to the ear molds. Anytime he put ear molds in his ears, it bothered him. He just was irritated by the ear molds, but he loved to hear. When he was 5, he told me that he wanted a cochlear implant, and I said, okay. So he did have surgery, and he had one cochlear implant, and he's loved his cochlear implant ever since. Now, and we continue to go to that audiologist because that audiologist signs and has a good relationship with the community, the deaf community, and respects us. Now, we drive a long distance to go to that audiologist because of the relationship we have with that audiologist. So all of my children go to the same audiologist as my oldest.
Some common strategies for improving the patient-provider interaction and institutionalizing changes in the healthcare system include: provide interpreter services, recruit and retain minority staff, provide training to increase cultural awareness, knowledge, and skills, coordinate with traditional healers, use community health workers, incorporate culture-specific attitudes and values into health promotion tools.
Me sentí cómoda porque pues es más, ¿cómo le digo? Pues es mi idioma y me siento pues más cómoda para igual y si yo tengo alguna pregunta o alguna duda, pues es más fácil de resolver.
Include family and community members in healthcare decision-making. Locate clinics in geographic areas that are easily accessible for certain populations. Expand hours of operation. Provide linguistic competency that extends beyond the clinical encounter to the appointment desk, advice lines, medical billing, and other written materials. ASHA, also known as the American Speech Hearing Language Association, has a cultural competence self-assessment tool. The tool offers a number of checklists to heighten awareness of providing services to culturally, linguistically diverse populations. You can find it on the ASHA website. Why are social determinants of health important to our work? Social determinants of health are conditions in the environments in which people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. Health starts in our homes, schools, workplaces, neighborhoods, and communities. We know that taking care of ourselves by eating well and staying active, not smoking, getting the recommended immunizations and screening tests, and seeing a doctor when we are sick all influence our health. Our health is also determined in part by access to social and economic opportunities, the resources and supports available in our homes, neighborhoods, and communities, the quality of our schooling, the safety of our workplaces, the cleanliness of our water, food, and air, and the nature of our social interactions and relationships. Examples of social determinants include availability of resources and access to healthcare services, transportation options, family and social support, social norms, culture, and attitudes, socioeconomic conditions, language and literacy. There are many factors a provider should take into consideration when interacting with families. For more information on social determinants of health, you may use the link provided at the bottom of this slide.
Bueno, cuando al principio con mi hija sí era un poquito, porque como yo no manejaba y mi esposo tenía que estar pidiendo permiso en su trabajo y usted sabe, las citas eran muy frecuentes porque había que hacerle los moldes muy seguido porque como el pues Valerie estaba creciendo muy rápido.
¿Ha estado preocupada sobre el costo de las citas audiológicas?
Pues de principio sí, como decíamos, ¿y qué va a pasar? Pero ya después vimos que no.
An additional factor that may impact your interactions with families is implicit or unconscious bias. Implicit bias refers to the attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. These biases, which encompass both favorable and unfavorable assessments, are activated involuntarily and without an individual's awareness or intentional control. Residing deep in the subconscious, these biases are different from known biases that individuals may choose to conceal for the purposes of social and/or political correctness. Rather, implicit biases are not accessible through introspection. The implicit associations we hold do not necessarily align with our declared beliefs or even reflect stances we would explicitly endorse. Implicit biases are thought to be automatic, not only in the sense that they are fast-acting, but also because they operate without 1. Intention, in other words, they are involuntary and uncontrollable, and 2. Conscious awareness. For this reason, implicit biases have also been described as automatic or non-conscious. Social scientist David R. Williams stated, "This is the frightening point. Because implicit bias is an automatic and unconscious process, people who engage in this unthinking discrimination are not aware of the fact that they do it." Implicit bias develops early in life from repeated reinforcement of social stereotypes. Implicit pro-white bias occurs among children as young as 3 to 5 years old. The implicit association test is a computerized time-dual categorization task that measures implicit preferences by bypassing conscious processing. It is a part of Project Implicit, a collaborative investigative effort between researchers at Harvard, University of Virginia, and the University of Washington. The studies examine thoughts and feelings that exist either outside conscious or control. The goal is for self-education and awareness.
I have good hearing in my left ear. I'm completely deaf in my right ear. I don't hear anything at all in my right ear, but I do have pretty good hearing in my left ear, and I didn't want to lose what I had. But I remember the audiologist was very persistent pushing cochlear implants. They went ahead and scheduled appointments for the MRI and for surgery, and I felt like I was being rushed into this decision and thought, okay, if this is what I'm supposed to do. But my mom was so excited. And I understand my mom's position. She's hearing. She wanted her child to be fixed. I can't blame her for that. And then the day before surgery, I went in for a pre-surgical appointment or something like that. And I finally had the opportunity to actually sit down with my mom. And my mom finally asked me, she said, I realize I've never even asked you this question. Do you want it? And I said no, because I didn't want to lose what hearing I had. And my mom said, well, why didn't you say anything? And I said, well, it was because I felt like the audiologist never even asked me if I wanted it. It was just a conversation between the two of you without me.
Our implicit biases are not fixed or permanent and can be changed over time, but only by being aware and attentive to them and deliberately focusing on trying to change them, according to the Kirwan Institute. How can we overcome implicit bias in healthcare? It all begins with awareness. You can learn more about your implicit biases by taking implicit association tests, or IATs, through Project Implicit. There are some strategies that are used to help change these biases. Through perspective taking, the cognitive component of empathy, perspective taking can reduce bias and inhibit unconscious stereotypes and prejudices. Think about what others are seeing and hearing, what they are feeling, their likes and dislikes. Think about the past experiences of others. Emotional regulation skills. Clinicians who have good emotional regulation skills and who experience positive emotion during clinical encounters may be less likely to view patients in terms of their individual attributes and to use more inclusive social categories. It's easier to empathize with others when people view themselves as being part of a larger group. Partnership building skills. Clinicians who create partnerships with patients are more likely to develop a sense that their partner is on the same team, working hard toward a common goal. Outside of the office, what changes biases is exposure to different facts, realities, situations, and getting to know real people can change our stereotypes and biases about them. Parents are going to react to how you deliver the news. Your job has two roles: to give information, but also to give emotional support. Traditionally, audiologists have done a great job at delivering information to parents on diagnosis and treatment options. However, when it comes to providing adjustment counseling or emotional sensitivity, approximately half of audiologists surveyed by the CARE Project indicated that they were not trained or comfortable doing so. In fact, usually the only experience in providing emotional support comes from on-the-job encounters with families. It is very important that audiologists learn how to more effectively and sensitively deliver information to parents about the hearing loss diagnosis and intervention options. Parents react in many ways, and these reactions may not be comfortable. Some babies have other complicating factors, and hearing loss may be the least of the family's concerns. Some may deny that there is a problem. Others may isolate from family members, friends, and neighbors. Some, but not all, may embrace this as good news if they themselves are deaf. Over 90% of parents who have a baby born with hearing loss have normal hearing themselves, and the unexpected news is likely going to be more upsetting. The bottom line, no one can predict how parents will react, so we must be as sensitive as possible.
But then you tell your family all the results, and of course they say everything's going to be okay.
And then they came out and they said, I remember them saying, oh, we found some type of hearing loss or some loss. So I was thinking, oh, well, can't be that, just some. And then we went in and they were like, and I remember the words I was looking for. I didn't want it to be sensorial and I didn't want it to be profound. And they were the first words that came out of their mouth. And
everybody says, that's what they say is, it could be worse. And, you hear that a lot. And I think I've heard in other videos, which I hope is, it can't be worse. Not at that time. Someone tells you, wow.
Yeah, in that moment.
Tells you that something's wrong with your kid. No matter what it is, I can't. It can't be worse at that time.
It is important to remember that those of us who provide services for these families cannot be successful in counseling parents if we are unable to approach them without sensitivity to their emotional journey. Feelings just are and cannot be controlled. Behavior can be controlled, and how we deliver the unexpected news to parents will help shape their response.
Families know when you're there and when you're not there, and they get it right away. And if we can, if you're not ready to be there for families, you need to sort of go someplace and take 3 deep breaths and get yourself into a position so when you walk into a family, you're there. I mean, there have been times when I fortunately not many, but I can think of times in my life when I have not been ready to listen. And families knew that and therefore couldn't listen to me because we weren't communicating.
The goal of this training is to help you understand what types of emotions families might experience when unexpected news is delivered. Think about the unexpected news as an elephant in the room. The feelings that both you and the family experience are centered around that elephant in the room. Those feelings may be uncomfortable, and we will talk about ways to improve communication between you and the family. Hopefully, by the end of this presentation, you will have tools to help families feel more comfortable and less anxious about the outcome. Parents are dealing with an unexpected diagnosis. The dream they may have had for their baby suddenly may be changing. They may not know that it's okay to grieve or react to this unexpected news. Do you remember a time when you have experienced grief? Every person has had or will have a grief experience in their lives at some point. Grief is a process. Grief is a part of life. It happens to everyone. Grief comes and goes. Grief can have a positive outcome. Everyone experiences grief differently. Both families and professionals are impacted by grief. Grief is a journey. What is grief? Grief comes in response to many different life experiences: critical illness diagnosis, loss of a pet, inability to have children, body image issues, divorce, failure at school, failure at work, learning your child has hearing challenges. These examples may cause any individual to go through a grief period. Grief means different things to different people. If a baby is born with multiple issues, deafness may be the least of the family's concerns. Or if they struggled to just have the baby, then they may be okay with hearing loss. Men and women will react differently. The siblings and extended family will have different reactions. In some cases, hearing loss may even be celebrated and accepted in the family. Audiologists should be cognizant of all of these factors. There are several emotional stages of grief parents may experience. When parents receive news that they did not expect, usually the first reaction is shock. Parents are stunned because what they have been told doesn't fit in with the life they envisioned for their baby. Many feelings may surface and parents will react in some of the following ways: upset, cry, traumatized, hysterical, blown away. After the shock begins to wear off, many parents may enter a state of denial. Not my baby. This can't be happening to me. It isn't true. It can't be true. The audiologist must be wrong. Reject the news. Total disbelief. Parents will eventually begin to realize that this news is true, and then the pain sets in. Many words have been used by parents to describe this pain: aching, hurt, tortured, wounded, suffering, undone, anguish. When people are emotionally wounded, an immediate reaction often is anger. Parents who receive this unexpected diagnosis may become angry and start blaming others for it, even blame the other parent at times. Parents may lash out, becoming outraged and furious that this is happening to them. Depression may very well follow the anger. The truth sinks in. Parents realize that what they envisioned is indeed no longer their reality. Parents may have a sense of hopelessness for a period. We must always remember that this is part of a normal process of grieving. Usually, with the encouragement of others, parents will embrace the truth. They will realize that it is time to move forward and get the information needed to have a clear indication of what to do next. During this time, it is important for the parents to find a peace about the situation within themselves as well as with those around them. Remember that anger stage? Relationships can be damaged when parents lash out at each other. Parents cannot stop at the point of acceptance. Families must move forward to learn and understand how to best advocate for their child. All families want the best life possible for their children, and this is no different because their baby has a hearing challenge. Throughout the child's life, the parents and the family may find themselves experiencing some form of grief again. This is also normal. There will be transitions for the child from early intervention to preschool, from preschool to kindergarten, to elementary school, to middle school, to high school, and beyond. Parents will have some of these emotions surface as their child moves through these different periods. But then again, any family will have these feelings. Remember, grief is a part of life and can surface any time along the family journey. Here are the stages of grief that we just discussed. Not all parents grieve the same way, and some may go through all of the stages and others just a few. Grief is a journey. It is not easy getting from point A to point B. The journey can be messy and unpredictable. The journey begins before the baby is born. Parents anticipate the birth of their new baby, and a bond is established before the birth occurs. Many wonderful, happy thoughts occur. My baby will be perfect, beautiful, smart. But there is news that comes in some cases that is unexpected. You still have a wonderful baby. It's just a slight detour in your journey. A detour that wasn't expected. However, the destination is still beautiful. Here is a story that is often told to parents who receive unexpected news with the birth of a new baby. Welcome to Holland by Emily Pearl Kingsley. I am often asked to describe the experience of raising a child with a disability, to try to help people who have not shared that unique experience to understand it, to imagine how it would feel. It's like this. When you're going to have a baby, it's like planning a fabulous vacation trip to Italy. You buy a bunch of guidebooks and you make your wonderful plans. The Colosseum, the Michelangelo David, the gondolas in Venice. You may learn some handy phrases in Italian. It's all very exciting. After months of eager anticipation, the day finally arrives. You pack your bags and off you go. Several hours later, the plane lands. The stewardess comes in and says, "Welcome to Holland." Holland, you say? What do you mean Holland? I signed up for Italy. I'm supposed to be in Italy. All my life I've dreamed of going to Italy. But there's been a change in the flight plan. They've landed in Holland, and there you must stay. The important thing is that they haven't taken you to a horrible, disgusting, filthy place full of pestilence, famine, and disease. It's just a different place. So, you must go out and buy new guidebooks, and you must learn a whole new language, and you will meet a whole new group of people you would never have met. It's just a different place. It's slower paced than Italy, less flashy than Italy, but after you've been there for a while and you catch your breath, you look around. And you notice that Holland has windmills, and Holland has tulips, and Holland even has Rembrandts. But everyone you know is busy coming and going from Italy, and they're all bragging about what a wonderful time they've had there. And for the rest of your life, you will say, "Yes, that's where I was supposed to go. That's what I had planned." And the emotions connected to the unexpected news will never go away because the loss of that dream is significant. But if you spend your life grieving the fact that you didn't get to Italy, you may never be free to enjoy the very special, the very lovely things about Holland. A diagnosis of hearing loss will be unexpected in most cases. However, in some cases, the unexpected news may be that the baby does not have hearing loss. Remember that families will differ in their emotional reactions. Think about how you will deliver the unexpected news. You need to plan ahead and be confident in how you will deliver this information.
I remember she's asked me specifically, Mrs. Bennett, are you shocked? Are you surprised? Like kind of curious as to why we're surprised. I mean, we've had 3 months and we've had all these re-screenings at the hospital, and I said, well, yeah, they just kept saying it was fluid. And they, no one ever said it really is a very strong possibility after this 2-week outpatient that there's a very strong possibility there is something permanent here.
And so the emotional journey begins. Parents learn something different from what they expected. Professionals, as they should, dump lots of information on the parents because it is their job to do so. Parents are usually not allowed enough time to process the emotional reaction to the unexpected news. Professionals may feel uncomfortable and or untrained to lend emotional sensitivity to the parents if they do get upset.
They finally come and get me, and they pull me back there, and she tells me Madison does have a mild to moderate hearing loss. And I don't even think I heard those words that day, because I'm holding my baby. She's screaming, she's crying, she's disoriented, she's upset. And then the questions start flowing. Well, can you stop today? And can you get her fitted for ear molds? And we'll pick out hearing aid colors and this and that. I could have picked out black for all I knew that day, but we picked out purple. And I think that next month, because she actually got her ears and her ear molds on March 8th, which is her hearing birthday, it was a month that I didn't deal with it.
What you say and how you say it will have impact on the families. You don't want to dump a lot of information at once. Anytime unexpected news is delivered, only the first 2 sentences are most memorable. Many parents have shared how news was delivered by audiologists. In addition to the information dumping, audiologists may avoid eye contact, dismiss the results and blame it on broken equipment or possibly fluid in the ear, nervously talk, tell parents how to feel, tell parents what you would do, tell parents that it could be worse or that everything is okay. When faced with shocking news, humans go to a different place in the brain. Memory shuts down. Information is not processed. Yet professionals tend to overwhelm parents with information. This, in turn, can lower self-esteem. A critical strategy that is highly recommended is called hitting the pause button.
He was diagnosed at 2 weeks of age with a moderate to severe sensorineural hearing loss at 1 year. And the news was shocking. I think probably every parent who gets the news probably goes into the diagnostic evaluation ready to hear bad news, but it's still shocking. The great thing that we heard on that very first day of diagnosis was that we didn't have to make a decision that day, that we had time to process it, and that was such a gift. Sorry. And so that's what we did. We had time to think about it and to grieve it differently, but also share that experience with one another, which was so wonderful.
Once you have shared the diagnostic results, stop and ask what questions the parents may have. Ask them what they need. Some parents may need time to process the news while others may not. Some parents may become emotional. Don't leave the parents hanging with no closure and no plan. Take a break before giving more information and make sure you establish a plan for follow-up. Here are some summary points to remember from this training video. Parents' reactions can be unexpected. Remember to hit the pause button and give parents time to think. Grief is a process with many stages. Keep it simple. Avoid unfamiliar medical terms when explaining results.
The thing that frustrated me so much with audiologists was they would use acronyms. And I didn't know a thing about it. He'd say, well, maybe you should go to DPI, or she's gonna need an IEP and stuff like that. Well, I had never been exposed to stuff like that, and I hated to ask questions, so I'd leave there just so frustrated and not knowing what he was talking about.
Remember EHDI 136 goals. By 1 month of age, screening. By 3 months of age, diagnosis. By 6 months of age, early intervention. Prepare the parent for the diagnostic appointment. Keep in mind cultural competency, implicit bias, and social determinants of health. Use an interpreter when needed. Historically, audiologists deliver information from a clinical medical perspective. The desired outcome of this training is to bring about a shift in the culture of how audiologists share information. Pediatric audiologists have a major impact on the lives of families. Families are on an unexpected emotional journey, and the sensitive sharing of information is essential to a positive outcome.
I probably have seen thousands of kids over the last 45 years, and most of them, families just are very attached. I mean, the families who think you should walk their kids down the aisle because you're the reason the kid is there, which of course is not the case. I'm not the reason the kid is there. I just helped them find the road. They did the work, and I just sort of helped move them along. But, that's what happens that makes this, that's why we do this work, because we look at these kids and we see we can help this family move ahead and have and even though they're in Holland and not in Italy, they can still have, this kid's going to have a terrific life.